When thinking about antibiotic stewardship, one of the fundamental pillars is getting it right the first time. We think about a patient with a serious infections, hours is of the essence. Given that culture and susceptibility results are not available for 2 to 3 days, it's highly important that we consider the likelihood of an antibiotic-resistant infection in a patient, ensuring appropriate coverage for suspected pathogens and the resistant profiles. So when we think about multi-drug resistant pathogens, certain groups kind of rise to the top, who's at greatest risk. And when I think about patients at risk for multi-drug resistant infections, I consider patients who come to the hospital with an infection and those who develop their infection during their hospitalization. When we think about people coming to the hospital with multi-drug resistant infections, really the patient population I think about most is our healthcare frequent flyers. Those coming from long-term care facilities, dialysis patients, immunosuppressed patients, patients with extensive prior antibiotic histories. So it's in those patients we have a heightened awareness for the likelihood of a resistant pathogen and also ensure our initial antibiotics have high likelihood of covering those pathogens. Similarly, when we think about hospital onset infections, the group at greatest risk for multi-drug resistant infections are those who have accumulated a number of prior antibiotic exposures. And what we find as people accumulate more and more antibiotics, they also increase their likelihood of developing a subsequent multi-drug resistant infection. So again, on both sides of the equation, coming to the hospital and developing during a hospital setting, we really think about time in healthcare facilities and time at risk, which is exacerbated by the receipt of prior antimicrobial drugs. When thinking about antibiotic-resistant pathogens, it's important to consider different classifications. Terms are used interchangeably within the literature, but the three most common terms are pan-resistant, multi-drug resistant, and extensively drug resistant. When we consider the term pan-resistant, what we're talking about is a bacteria that's resistant to all commonly used agents. A good example of this would be Pseudomonas, where all our commercially available beta-lactams, aminoglycosides, and fluoroquinolones have no activity against that bug. Multi-drug resistant, depending on the pathogen and the organization defining it, usually defines a bacteria that's resistant to 3 or more commonly used classes. So again, if we would think about a multi-drug resistant Pseudomonas aeruginosa, here we're talking about resistance to the fluoroquinolones and aminoglycosides and perhaps advanced generation cephalosporins. Another term that's often used is extensively drug resistant. Here we're talking about resistance, not quite pan-resistant, but a level above multi-drug resistant. So here when we think about Pseudomonas aeruginosa as our working example, here we're talking about resistance to 4 or 5 commonly used classes. Extensively drug resistant is often applied to Acinetobacter, given the high levels of resistance observed within that pathogen. So when we think about identifying multi-drug resistant pathogens, I think our first place we should look for data is from surveillance programs. So surveillance programs, these are national programs where they have sentinel hospitals, in the case of the United States, throughout the United States. And what these sentinel sites do is provide a central laboratory, a certain number of isolates for susceptibility testing. So here, this is a good benchmark as to, what are the resistant pathogens within your area and what changes have occurred from prior years. A good example of the importance of large-scale surveillance programs is what we're seeing with carbapenem-resistant Klebsiella pneumonia. Overall, we have a low rate within the United States, but we do see pockets that do have higher rates of carbapenem-resistant Klebsiella. In addition to looking at national surveillance data, it's always important to see what's going on at your institution. As a lot of these surveillance programs typically lag a few years behind real-time data. So probably one of the best glimpses of multi-drug resistant pathogens that may be problematic in your institution, one needs to look no further than what's going on at their own hospital with their local antibiogram. And as an example of this enabled us to identify CRE early in our institutions years prior, where this became reported within the national literature. And also we've been able to recently identify some resistant phenotypes within Acinetobacter as well. So again, not only is it important to look at surveillance data, but also to look at data within one's institution. When we think about multi-drug resistant bacteria, often what we're talking about is, the presence of an organism that has different resistant mechanisms. And these different resistance mechanisms confer resistance at different classes of antimicrobials. Probably the one that we're most concerned about is beta-lactamases. So when I think about beta-lactamases, why there's different classification schemes, I really put them in three different categories. Your broad spectrum beta-lactamases, your extended spectrum beta-lactamases or ESBLs, or your carbapenem resistant beta-lactamases. So when we think about broad spectrum beta-lactamases, what we find here is these beta-lactamases hydrolyze, first and second generation cephalosporins and some of your commonly used penicillins. In current times, most Enterobacteriaceae and other problematic gram-negative bacteria possess a broad spectrum beta-lactamase. ESBLs or extended spectrum beta-lactamases. What we have here is beta-lactamases that actually hydrolyze third generation cephalosporins, H-treonams, and they may or may not be inhibited by clavulanic acid or other commonly used beta-lactamase inhibitors. So here, these are very problematic organisms. Depending where you are, about 10% of all Enterobacteriaceae express in ESBL. We find the highest rates in Klebsiella pneumonia, followed by E. coli, but can be present in other organisms like Enterobacter as well. For your carbapenem-resistant beta-lactamases, these are the most problematic. Really come in two varieties, your serine or KPC producing beta-lactamases here, commonly found in Klebsiella pneumonia, really the one that's problematic with the United States. And then another emerging phenotype, which is seen worldwide but becoming more prevalent in the United States, is your metallo beta-lactamases. The NDM strain, I think we're all familiar with. This is the New Delhi beta-lactamase. Very concerning because a lot of our new beta-lactamase inhibitors brought to market have no activity against gram-negative bacteria expressing MBL-producing beta-lactamases. An important part of identifying multi-drug-resistant pathogens is to look at the data that's brought forth from our clinical microbiology labs. An issue that often comes up is, are we accurately capturing resistance within our institutions? So in the past, there was a sense that we were probably underestimating CREs due to the susceptibility breakpoints being too high. Since they have been revised, I think we're at a point now where we are identifying CRE at an appropriate level. One resistant pathogen that I don't think we're identifying well is when we observe colistin resistance. You may or may not be aware, the Enterobacteriaceae, we do not have a defined breakpoint. We infer it from other pathogens. And also, too, when we do colistin testing, there's very specific methods and mediates that are now recommended. Not all institutions perform this. So the one, antibiotic where I feel a bit hesitant relying on susceptibility data is colistin. So again, I think we all need to look carefully, ask our microbiology lab how they're doing susceptibility testing, and making sure that they're following best methods.